Tina, we're unable to hear you at the moment.
Thank you to my colleagues. The one thing I forgot to do was click the unmute button. So hello, everybody. Let's try that again. Welcome this afternoon. I'm going to get going on the introductions while I'm sure that people will be joining us over the next few minutes. My name is Tina Strack, and I'm an Associate Director at HQIP, and it is such a pleasure to be hosting today's session. We're scheduled to finish at 1:30 p.m., and so massive thank you to you all for joining us over here on your lunch break. For some of us, it is very hot, and we're very grateful that you've taken the time to join us. Today's webinar forms part of Clinical Audit Awareness Week 2026, which is a week-long campaign that celebrates the role of clinical audit and healthcare data in improving care for patients. So throughout this week, we've been looking at different aspects of improvement. And today's theme is one I think that sits really at the heart of everything that we do, patient safety. Clinical audit isn't just about measuring performance. Done well, it helps us to identify risks, understand variation, reduce harm, and ultimately to build a safer healthcare system. And today's award-winning projects are fantastic examples of that. So as part of today's sessions, we're going to be announcing the winners of the Patient Safety Award before we hear directly from the winning team about their work. And we'll also hear some reflections on local improvement work, and we'll finish with some questions and discussion. Next slide, please. So just a few housekeeping points before we start. Everything you need to know is on the screen. So today's session is being recorded, and we'll make the recording and slides available afterwards where possible. Everyone's mics are muted automatically, so keep the background noise down. We encourage you all to turn your cameras on, appreciating, of course, some of you may be having lunch. It can be a little unnerving to present to little squares, so we're grateful if you can share your face. Now, rather than the chat, we're going to take questions to the Teams Q&A function, which is at the top of your screen. So please do submit questions as we go along, and we have a dedicated discussion towards the end. No need to wait until the end to submit your questions. Feel free to do them at any time. And lastly, a few technical aspects. So if you have any technical gremlins, for example, like accessing the Q&A, we've been advised that it's better to use Teams through a laptop than a phone, and the browser version seems to work better as opposed to the app. So if you are having any issues, maybe try that. If you still can't get a Q&A to us, and there's something you really want to ask, feel free to go to our website and use the Contact Us button. Someone is monitoring the inbox, and we can get your questions that way. And lastly, if the technology decides not to play nicely, bear with us for a few moments and simply rejoin either with the rejoin link or your original link, and we'll get going again as quickly as possible. Hopefully we won't need that, but I think it's always worth letting you know. Lastly, don't forget, if you are someone who likes to share things on social media, the hashtag for the week is CAAW26. We'd love to hear, you can share your thoughts on this session, other sessions, things you're doing locally this week. Do feel free to share things on socials. All right, well, there we go. Next slide, please. Now we come to one of my favorite parts of Clinical Audit Awareness Week, and it's having the opportunity to recognize teams who are using audit and data, not simply to measure care, but to improve it. I've previously been on the awards panel, and it's always so inspiring to read all of the award entries. We always say this, but it's true. This year's Patient Safety Award attracted a really strong field, and the judging panel commented on the high quality of entries and the practical improvements being delivered for patients. So next slide. I am delighted to announce that the runner-up is virtual drumroll. Next slide. Clay Ponds Hospital, West London NHS Trust for breaking the fall, reducing harm from inpatient falls at Clay Ponds Rehabilitation Unit. The judges were particularly impressed by the measurable improvements achieved in reducing falls, together with the thoughtful multifaceted approach taken to tackling what's a very complex patient safety challenge. So big congratulations to the whole team. Next slide, please. And I'm delighted to announce, I wish I had a virtual envelope to rip open, to announce that the winner of the 2026 Patient Safety Award is, next slide, the Dermatology Department at Sandwell and West Birmingham NHS Trust for monitoring skin cancer MDT outcome compliance. Congratulations. Next slide, please. We're now going to hear directly from the winning team. I'm particularly pleased to be introducing this project. Earlier in my career, I worked in cancer services, so I know just how important multidisciplinary team meetings are in ensuring patients receive timely and appropriate care. So Karisma and Sonika, congratulations once again. Thank you so much for joining us, and I'm going to hand over to you.
Thank you so much, Tina, for introducing us. We're very delighted to have won this award and to present our data on the skin cancer MDT outcomes audit. So Karisma and I will be presenting this data today, and we've got special thanks to Dr. Michelle Thompson and Anne Rutland and Amy Noon, our skin cancer CNSs as well. This is a picture of our team from the Christmas dinner that lunch that we've had in the department. Next slide, please. So just to give a bit of background on skin cancer. So skin cancer is the most prevalent cancer in the UK, consisting of 1 in 4 new diagnoses, with 19,392 cases of melanoma subtypes in a year. And there's an upward trajectory, especially when we think about how hot the weather's becoming and how much UV we're getting. We're going to see more and more skin cancer in the future. It's the 9th highest incident rate of melanoma in the world, and older patients are particularly affected because of the aging population, and the cultural shift towards UV exposure is now becoming more apparent. Next slide, please. So just in comparison, you've got Norway, Denmark, Sweden, the countries, the Netherlands, they're all quite high up on the incidence, but the UK doesn't fall too far behind and has got a very high incidence. And, you know, every year we're seeing on the national news that melanoma skin cancers are hitting a record level high. Next slide. So in 2022, there was the NHS is definitely feeling the pressure, especially post-COVID, of increased number of skin cancer referrals. The skin cancer referrals do need to meet targets, and they need to be seen in a timely manner from GP referrals. And 128 organisations sought 253 urgent suspected skin cancer referrals, from a 2.6-fold increase. Skin cancer MDT services are a gold standard framework to direct collaborative multidisciplinary care for patients with those with a suspected skin cancer. In our trust, how it's structured is we have a kind of regular 2-week, every weekly skin cancer MDT, which comprises of dermatologists, plastic surgeons, histopathologists, oncologists, dermatology specialist nurses, and oculoplastic surgeons. So every week we have this on a Monday, and this is where urgent referrals are discussed. So the histopathology reports are flagged as to this showing a skin cancer. And then the electronic performer is completed by the dermatologist that's overseeing the patient. So we get the list kind of every week, stating that these are the reports that are flagged, that come up as skin cancers, and the consultants are asked to complete the referrals and then present the patients on that Monday. When we present those patients, we present using medical photography, and there's a discussion with the histopathologist there on the findings, and then we decide the management, whether that means surgical management, radiotherapy, other forms of management, as well as what the follow-up plans would be. Next slide, please. So the aim of our audit was to assess the compliance of the outcomes to skin cancer MDT within our trust. Previously, this has been done, so it's done particularly before COVID, and there was quite high levels of compliance, 98%, 99%, 97%. But after COVID, we did notice a drop of 89%. And there was a concern that, after COVID, there is a concern of more virtual working, more referrals, more burden of skin cancer. Whether this has now changed, we also are noticing a fluctuation difference in our team, less consultant bodies. So how does that then impact the skin cancer MDT? So that's what we were trying to measure the compliance. Next slide, please. So we registered our audit and we completed 2 cycles which captured data from all the MDT outcomes we picked 2 months, July 2025 and February 2026. We looked at the lists of patients discussed in that MDT. So that was 4 MDTs that month. Both months didn't have any bank holidays. Even if there is a bank holiday, they're usually still done on a Tuesday. We make sure we do not miss the skin cancer MDT on a weekly basis. And then we collected that data and we compared the MDT outcomes against the electronic record, whether that the pro forma has been uploaded, whether the clinic appointments have happened that I've mentioned about follow-up, or the surgery, or the investigations that were requested, such as the vitamin D or any CT scans. And we measured whether those MDT outcomes that were discussed in that meeting have been met or not, and if there were any deviations from the MDT outcomes, and if so, have the deviations been documented? Has that been discussed? And usually if there is a deviation from the MDT outcome, so if that outcome hasn't been fulfilled, that deviation should trigger a repeat MDT discussion. So whether that has happened or not, and also whether those photos were available for that to be reviewed, because if the photos aren't there, that's really difficult to discuss that patient for the MDT without the photos. So then it has to be rolled over to the next week, and then that delays patient care. I will now pass on to my colleague Karisma on the next slide.
Thank you, Sonika. So I'm just now going to talk about the results that we had from our initial audit, as well as our second audit cycle. So in the first cycle results, so we looked at 4 consecutive MDT meetings that took place in July, from July the 7th to July the 28th. And we looked at every single case of patient that was discussed in those MDTs. And in total, 39 cases were discussed. 1 patient was a rediscussion, and the reason that took place is because, as well as having a local dermatology MDT meeting, we also refer patients for more specialist input at a tertiary centre, which is called a skin specialist MDT meeting. So patients, for example, who have complex melanoma and require more oncological or plastic surgery or more specialist dermatologist input. So once that patient had that outcome, we then rediscussed them. We then looked at every single outcome from those cases, and we found that 28 out of 39 cases, all of those outcomes were met, meaning that there was a 74% compliance rate, also meaning that approximately 1 in 4 cases or outcomes for those MDTs were not met. We looked through medical records, and there could have been lots of different causes as to why the outcomes were not met, or maybe there was a variation, but it was very difficult to trace those deviation reasonings. And so that also provided a point of governance for us to look at, as well as patient safety. In total, there were 3 cases that were lacking clinical photographs, and as Sonika has already mentioned before, clinical photographs are very important when looking at a skin lesion and deciding on the management, and so it's important to have a look at areas to improve this as well. So when looking at all of the outcomes, there were various reasons as to why there was a deviation. The most common deviation was a change in allocation for a follow-up consultant following the MDT process. So usually we prefer having the same consultant following up patients when they are diagnosed with the skin cancer as a continuity of care point. If a consultant has a good background knowledge of a patient, then it's beneficial for them to then be following up the patient and then having surveillance over that patient if they have further skin lesions, or having overall management of their care. But as Sonika has already pointed out, due to different workforce pressures, it can be quite difficult for that to be maintained not only at our hospital but across all departments and across all hospitals. Other causes of deviation included a change in treatment or imaging investigations that was carried out, and another deviation was an outpatient date. And when we looked back at all of the records, it was quite difficult to trace sort of where the variations were. And so if we go on to the next slide, please. We then planned our intervention. So looking at the deviations, you can see that there's lots of different teams that that deviation might sort of different team members that can help with meeting those deviations. And so what we did was we presented that audit cycle, the results of our deviation, to the entire Department of Dermatology, because lots of different team members can then come together and come up with some interventions that can help improve those deviations for the next cycle. And that was very useful, actually. So we presented at our QIHD presentation meeting, and we discussed with lots of different staff members, dermatology consultants, CNSs, secretaries, administrative staff members, and we engaged all the team, and we conducted the Plan, Do, Study, Act framework, which is sort of a golden framework for planning QIHD projects. And we came together and we came up with 3 different targeted interventions. So the first one was looking at peer-led teaching, so making sure that we create a standardized approach when reviewing skin MDTs. So whenever a patient has a outcome from a skin MDT, we then incorporate those outcomes as part of the documentation process as a standardized template within clinic letters or follow-up appointments, to ensure transparency behind deviations of outcomes, as well as to ensure that outcomes are reflected on and carried out as much as possible. And the way we did that is by creating a guide for clinicians and incorporating that within the induction materials, because in a lot of departments you have a high turnover of staff, and ensuring that this kind of guide is then incorporated into induction materials is a way to help promote standardization and long-term sustainable change within a HQIP, for example. Other things that we also looked at was working with admin staff and seeing how we can promote continuity of care within our team and promote follow-up appointments as much as possible. And then the third point was optimization of our EPR system. So we're very fortunate that at our DGH we do have an electronic system, and we looked at ways of promoting efficiency and tools within that to help sustain outcome achievement. So next slide, please. So 6 months later, in February 2026, we did a re-audit where we conducted the exact same methodology, and we looked at all 4 MDTs from that month, from the 2nd to the 23rd, and 49 cases were discussed in February. And we found that, very fortunately, we had an increase of around about 18% of our, from 74% to 92% of achievement of the outcomes, which was quite a good achievement to have. 45 out of 49 outcomes were achieved. And when looking at the deviations here, we found that the most common cause of deviation was treatment, a change in investigation, and a letter that was awaiting. But all of the reasons for those deviations were documented and seen within the system. So we were able to trace those reasons for variation. So overall, in promoting achievement of outcomes and hopefully patient safety as well. So next slide, please. Just a bar chart to show how within each MDT we had an increased achievement of outcomes throughout. Next slide again, please. So we presented both audit cycles at a QIHD meeting, so at 2 separate meetings, and our team are very happy to hear these results, and we discussed how we can make sustainable, meaningful change. There's 3 learning points that we found from this project in total, is that MDT outcomes is an essential part of patient safety. We need to make sure that if we're collectively gathering people and their expertise, that we ensure that their expertise is carried out in the long term, and that if there's any reason for deviation, whether it's part of the governance process and patient safety process, that there's reasonings for that, and that it's completely accountable within the system. Conducting a closed loop audit cycle, so where we conducted a first loop of audit and then a second cycle of audit, it helps promote meaningful improvement if you're able to see the changes that are made and then reflect on those interventions and see whether they're actually making an impact or not. And then the third is gathering all of your MDT. So we discussed with every single person in the dermatology department who contributes to MDT, and that's essential for making this project a success because we can't carry out an MDT without these members, and they all contribute in a specific way to help make the MDT successful. And so that was what helped create positive change in the project as well. And there's just a picture of us, of the core team members of this project, including our consultant and Anne, who's our CNS as well. So we're all thankful to them for helping. Next slide, please. And those are just references of all the information that we've used. And I think the last slide is just saying thank you to everyone who's listening, and we're open to questions as well. Thank you.
Oh, that was absolutely brilliant. Thank you so much. We're going to do questions at the end, just to remind everybody. There is a Q&A function at the top, so do feel free to put your questions into there. I really want to thank you to both of you for that presentation. I really enjoyed hearing about your work. In another life, I wear a different hat. I'm involved as a governor in a trust, and in that role, I've been part of assessing awards there. And I'm always so impressed when I see clinical colleagues and administrative colleagues coming together. I just think it really strengthens something, and you've shown that. And I think what really struck me about your project was it started with a maybe deceptively simple question. Are the decisions we make in MDT meetings actually being translated into practice? And you brought the whole team together to close the gap and improve compliance. And it's just such a great example of how relatively small changes can really strengthen an entire clinical pathway. So thank you so much for sharing it. I really enjoyed hearing that. Next slide. We're now going to hear from Vicky Patel. Many of you probably know Vicky from her previous Clinical Audit Awareness weeks. Vicky and I have done the awards for patient safety together a few times. In her former role as chair of HQIP, she became well known for sharing her reflections on each of the award categories, and those sessions were always extremely popular. So we are delighted that she has agreed to continue that tradition this year, and she's going to bring her own local clinical audit perspective, and I'm sure some practical ideas and inspiration. So Vicky, thank you so much for joining us again, and I'm going to hand over to you.
Oh, thank you so much, Tina. So yeah. So obviously setting our thoughts again now, just to move on to that local reflection then around the fact, and I think you've already said it, Tina, about preventing avoidable harm. It is one of the most fundamental responsibilities that we've actually got in the NHS, and clinical audit plays a critical role in this, but only if it's used effectively. And I've touched on the 10-year health plan every day this week, so I'm going to do it again today. But it really sets out that clear direction for the 3 shifts from sickness to prevention, hospital to community, and that analogue to digital. And if we align clinical audit to these shifts, it becomes probably one of the most practical tools that we've got to identify risk early, intervene sooner, and prevent harm before it happens. So the problem we've probably currently got is that clinical audit it's not always being used effectively to prevent harm. So we need to have that focus on that harm prevention. At the moment, it's often still retrospective. We've got that a lot of emphasis on that report focus, and we've often got quite delayed feedback coming through. So by the time those findings come back, the patient might already have experienced that harm. The opportunity to intervene earlier has passed, and learning's not always translated into that immediate action. So the issue is not whether we're auditing, the issue is whether we're actually using audit in a way that actively prevents avoidable harm. So if we move on then and start to think about how we could then reframe clinical audit then to prevent avoidable harm, we've got to start to look at repositioning clinical audit. So we're going from that retrospective assurance process to that real-time safety and improvement tool. It is a very, very powerful tool. So that means that we've then got to use audit to identify deterioration early, detect that variation in care, highlight any missed opportunities for intervention, and then provide that rapid feedback to our teams that are on the ground. So I suppose audit shouldn't just tell us what went wrong, it should help us stop it happening again in real time. So if we move to the next slide, then we can start to have a look at what that might look like in practice then. So 5 practical ways here for clinical audit to prevent avoidable harm. So the first focus is on that early warning signs. So actually looking at audits around deteriorating patients. So it might be your news 2 escalation, delays in reviews and missed triggers. That allows us to identify where patients are not being escalated or reviewed in time. And that's a key driver of preventable harm. And then audit missed opportunities for prevention, not just was care delivered correctly, but actually could we have prevented this deterioration? So your sepsis recognition delays, failures to initiate preventative measures and missed risk factors if you think about your frailty, your falls and your infection. And then we've touched on this a lot as we've gone through the days already this week, looking across that whole pathway. So you're not just looking within your team, within your clinical area that you're working, but you're starting to look across that whole patient pathway from admission to treatment, discharge, community. Many harms occur at transitions, and it's poor handover, delayed follow-up, incomplete referral. Think about using your real-time rapid cycle audits, your short cycle audits, weekly, fortnightly, immediate feedback to teams. This is where the impact happens, when teams can start to act immediately, not months later. And then finally, the 5th one around using that digital data intelligently. So use your EPR systems, time-stamped events, use some of your automated dashboards that we're now starting to see introduced into many of our organisations. This reduces burden, and it does actually enable us to have that real-time visibility of risk. So if we move to that next slide, then we can start to think again about how that aligns to the 10-year health plan then. So sickness to prevention then, think about identifying that risk earlier, acting before deterioration happens. That hospital to community, auditing the pathways way beyond discharge if they've had an acute hospital admission, preventing readmissions and obviously harm that might take place over transitions between teams and care settings. And then that analog to digital as well, using that digital data for that real-time insight, faster escalations, and of course that better decision making. So clinical audit, as we started out, then it can become a tool for delivering the future model of care in terms of what we want health and care to look like, not just measuring that past. So if we move on, then we'll start to look again then at the true power of effective clinical audit then. So when we use it effectively then, and we're thinking now with that patient safety head on, we're trying to prevent avoidable harm here. Detect risk early, make sure that we're intervening sooner. We're looking to reduce those delays in care. We want to be consistent, and we want to prevent those avoidable complications. And ultimately then, we should see fewer incidents of harm. We should be seeing those improved patient outcomes, and then we see safer, more reliable care. So effective audit turns insights into action, and action into improving care and outcomes every day. So then if we move to the next slide then, and we'll start to look at concluding and bringing all of that together then in terms of what's been shared with you so far today. If we want clinical audit then to truly help prevent that avoidable harm, we've got to start using it differently. So we've got to make it faster, we've got to make it more relevant, we need to make sure that it is actually embedded into care, and that we've got that focus on prevention, not just compliance. So clinical audit shouldn't sit at the edge of service delivery. It should sit right there at the heart of how we're identifying risk, preventing harm, and improving care every day. And when we use it well, clinical audit doesn't just measure safety, it actively creates it. So thank you.
Marvelous. Thank you so much, Vicky. That was great. And I really like your point about, you know, the audit shouldn't be something that's done to teams. It's something that's done with them to help prevent harm and improve care. I also thought it was interesting. It's related, it's sort of linked to the project we've just seen, where they started with a question, involved the whole team, made some relatively simple changes, and then measured the difference. And that's really clinical audit at its best, and that will prevent future harm. So that was fantastic. We've had loads of questions. Thank you so much. So keep going if you have questions. That would be wonderful. I'm going to now call on my colleague who has been monitoring the Q&A to pose some questions. We're going to move to the Q&A session. And I think we'll shortly be able to see all the speakers again. That would be great. So Lacey, are you
Thank
able
you,
to?
Tina. Yes, I'm here. So I have been looking at the questions. I'm going to get through as many as I can. I promise you I will. If you could keep asking your questions to all three speakers, that would be great. So I'll kick off actually with a question for the winning project, which came from Tina, in fact. I think it's a really good question to ask. Sometimes we overlook the more simple things, which is one of the things that struck Tina about your project was was that the interventions themselves are relatively simple. And sometimes bear in mind, the more simple things are the hardest things to do. And looking back, was there one particular change that made you think made the biggest difference to improving compliance?
Thank you, Tina. That's a really good question. I think in general, we really wanted to make sure that our compliance levels were reaching, top levels, and we were meeting all our goals. And I think when, as Karisma explained, the results with our results, that there can be a deviation in terms of the investigations ordered, and sometimes if the consultant, for example, isn't there, are they making sure that the patient is getting those vitamin D results checked, those CT scans? Are they getting letters to even explain that this is, or the appointments actually? And a lot of patients might be not even getting the appointments in the timely manner to then discuss that this is the outcome from the MDT, perhaps if surgery is suggested or if radiotherapy is suggested, and really making sure that we get those appointments booked is really key. And I think that liaising with the secretaries as well and the admin team and having that loop is really important to make sure that those patients are getting their appointments on time, and then they can then discuss whatever's been actioned in the MDT. And that appointment then also gives a chance for the clinician to reflect on, this was the outcome from the MDT, put that in the letter, discuss that, and then make sure all of the results are being actioned.
Great, thank you. And then, this is Clinical Audit Awareness Week after all. We've had a question around, you did mention closed loop audit, but we had a question around, could you explain if local clinical audit staff were involved in your project and to what extent?
Yeah, so I can answer this question. We had a local audit team sort of lead, and she really helped with this project. So this project, this audit was carried out pre-COVID annually as part of the national sequin audit targets. And so we have a registered audit code for this audit that happened, sort of like a division of the code. So she was really important ensuring that sort of reminding that this audit is really key to take place, but also ensuring that all of the audits that take place on an annual basis are collectively put under this code so that you can then compare the outcomes from one year to the other. She also helped us with registering. So we do have a standardized process in registering our audits within the trust. I think it's very similar trust to trust. But she was also integral in leading that. So in terms of the admin aspect, she really did help with that.
Great, thank you so much. And actually, one more question for you. Sorry to put all the questions to you to begin with. I'll bring Vicky into the conversation in a moment. But we've had a lovely question around getting buy-in from stakeholders and including patients, given this is Patient Safety Week. So someone says, I want to give you this quote directly. Thank you for giving hope that big improvements are very much achievable. I think that's a lovely quote. But how did you get buy-in from your stakeholders?
Yeah, so I think that's a really nice quote that was given, and patients are at the heart of what we do, and that's really important. I think, yes, like Karisma mentioned, speaking to our consultant and then the other consultant bodies were really helpful to know whether this was something important and whether it is worth us checking this and getting the buy-in with presenting this at our quality improvement meetings, which has a multidisciplinary approach of our nurses, our consultants, our registrars who also see the patients, and then also presenting this at our skin cancer MDTs, so that they're aware of what we're doing and what work is happening. And I think what I know when I see the patients in clinic, I do make a point to mention that you were discussed in our skin cancer MDT. This is an MDT that consists of multiple professionals. We look at your images, we discuss your histology, and we decide that this is the best approach. And I have kind of highlighted that so that patients have the buy-in. They understand that, you know, it's not just a decision that's being made by one clinician that's looking at their report and deciding that it's made as a joint effort and collaboratively. So I think giving patients that awareness of what we're doing with the MDT is important. And then sometimes that does, you know, patients themselves say that if they've got multiple lesions, if they're under the melanoma surveillance, for example, they already know about the MDTs. And so they're aware that, you know, I see. So the reason why you're referring me for an extra surgery or for this is because you discussed that in the MDT, and that's what they think is best and all of that. So, yeah.
And a quick follow-up would be, was there anything that surprised you, or anything that worked rather better, or perhaps even was rather more challenging than you expected in terms of engaging people?
I think we were very fortunate. So I was actually going to add to the previous that we were very lucky in that in our audit team, it was multi-professional as well. It wasn't just doctors, it was also nurses that also helped lead with the audit. So we had buy-in from all those teams because it was multiple people leading the project rather than just one profession, which really helped. And so I think that added to the success. So we were lucky in that a lot of the changes that we made were very acceptable to the majority of our department because so many members were involved with the collective decision making. So when we approached the intervention stage, we didn't have ideas initially. We actually came to the QIHD meeting and took ideas from everyone. And so it was a collective decision that this is what our intervention will be. And so, yeah, we were very lucky in that.
And congratulations. So I'll bring Vicky into the conversation. I'll bring Vicky into the conversation again, starting with a question from Tina. So Tina's keen to know, because today's session is obviously focused on patient safety, looking ahead, where do you think clinical audit has the greatest opportunity to prevent harm rather than simply identify it after the event? We've heard lots this morning about Martha's Rule, which is very much focused on before the event. So we'd love to hear from you around opportunities for clinical audit to sort of intervene there.
Yeah, it's always done after the event, isn't it? And it's so this is about you really getting to know your patient groups and your local communities so that you're already knowing where your pockets of risk potentially might be, so that when you're pulling that audit programme together at the beginning of the year, you're already starting to highlight some of your topics, your hot pockets where you're thinking, actually, we need to do a piece of improvement work there because actually we could be sitting on risks or harm about to happen. A lot of this is about triangulation. You don't work in isolation alone. We're waiting for that national quality strategy to be published, aren't we? And we've all got a local one back in our own organisation, and it brings Darcy's triangle together really nicely still around effectiveness, experience and patient safety. And actually, if you're not yet working with all the central teams within your organisation to align your programme of improvement priority work, you need to be, because you need to be now triangulating everything that you know within your own organisation and again with your partner organisations across your system. So you should know what common themes are coming up, and you should start to be looking to predict things. Actually, where do we think we might have some issues or concerns coming up? And actually, it's not just about what we think. We've heard about the patient and public involvement on Tuesday. This is about actually the people that are using our health and care services. What are they telling us? What truly matters to them? And how do we then bring that in and triangulate it with everything else that we know to inform where we need to be placing our resource to measure? We've not got an infinite amount of resource. We know that it's a big ask with this 10-year health plan. The reason we've got this is because people are living for longer and they're not necessarily living well for longer. And we've now got to look at equipping individuals to make sure that they are looking after themselves so that then we have got an NHS for the future that can support all of us. So yeah, let's get talking, let's get knocking on the doors of all the teams that you need to be working with. And that's not just in your own organisation, it's your partner organisations across your system. And don't don't forget the patient and the people in your local communities that are at the heart of everything that we're delivering. There's quite a bit in there, but I think until you start understanding what you already know and what you don't know, clinical audit's not always the answer for the problem that you're trying to solve or what you're trying to find out, but actually this is about data-informed improvement. This whole week's focused on that, and sometimes clinical audit's the right activity and sometimes it's other QI methodology. I'm an absolute advocate of clinical audit and I love it, and it's based upon evidence-based standards, so I'll always promote clinical audit. But yeah, you need to start talking to each other, and that's frontline teams, corporate teams, and across organisations as well. Sorry, that went quite widely, that response.
That's great. There's a question in the Q&A that refers to the Ockenden report that came out last night. I spent the evening myself reading this report. I'm sure many of you did too. If I might be so bold, I'm not sure I agree with quite the assessment in the question. I don't necessarily agree that audit was savage, but I'd love to hear from not just you, Vicky. I think it's a little bit too much of an ask just for one person to answer this question, but I wonder if you, Tina, our winning team, have any thoughts on how we might be able to utilise clinical audit more to prevent the sorts of harms that we all read about last night in the Ockenden report. Maybe, Tina, if you'd like to have some thoughts first.
I'd love to. So the reason Lacey is passing this, I think, particularly to me, is here at HQIP, the audits that I work most closely with are actually the maternity audits. So I know this space quite well. And I think I've got two reflections. There's a lot going on in my head since yesterday. One is that I think what the report really showed is that there were these different places where messages were coming out, but no one was putting the whole picture together. So you've got messages from patients, you have a confidential inquiry, you've got PSERF information. And I think the system, certainly the people I work with in the last 3 years, they're doing that in a better way. So I have hope, I have optimism for the future that we are triangulation, whatever you want to call it. We're looking at the big picture. My other reflection is, fairly or unfairly, again, a bit from my role as being a governor, is that importance about clinical governance. That's such an important piece, and making sure the right people are getting these messages, because they are often the ones with the leadership to take things forward. So those are sort of my initial thoughts, and it's so tricky. Vicky will say something much more intelligent than that.
No, I'm just going to build on what you're saying, Tina, in terms of there is absolutely no room for complacency here. So if people, and I just think even if people think that clinical audit didn't fare very well in that, for me, that whole review, there is so much in there and there's so much for all of us to take. So even if you think, well, actually, we're quite happy with maternity services in our organisation, I don't think anybody can sit here and say that, because there is something to be learned for everybody. I think in any of these reviews, whether it's the Ockenden report or whether it's any of the other ones that are due as well, yeah. Clinical audit will help us if we apply it effectively, which we've touched on already, haven't we? You can do clinical audit not well at all and you're not going to get the results, but it is a really powerful tool if it's actually used well. But I think first and foremost, people need to read it and they need to reflect, and you need to be talking together collaboratively within your organisation, your system, which we've touched on in the previous answer to the previous question, and obviously you've mentioned it again now, Tina.
And this may be just a little unfair. I'd love to bring our winning team into this, in that obviously it's not your sector, but just any thoughts from your experiences on how audit can prevent harm in the ways that we saw yesterday in yesterday's reports?
Yeah, sure. I'm happy to see that. I know it has been getting a lot of interest, and a lot has been highlighted recently, especially in the news as well. I think it's really important to get the clinicians that are involved kind of on the front line with this, for example, the maternity service or any department that we're looking at involved. But I think the biggest pressure that they're facing is their clinical duties and their demand, and that's pulling them away from getting time to do audit and to do the cycles and the interventions and to do it properly. And I really think that we need to make sure clinicians are getting protected time in their work schedule or their job role to be able to engage in audit, and that comes at all levels, whether they're a trainee or a nurse specialist or they're a consultant. I think at every level we need to make sure that there is protected time to be able to you know, be able to do audit, because you're going to get the best ideas and from those who are actually directly involved in the front line and seeing patients every day and dealing with these issues daily, and they'll be able to know what are the best kind of audits to think about, what are the best interventions. But the problem we have is just time, and we're so busy with our role, so we just need to give them time.
Thank you for that.
Thanks.
It's so powerful to hear clinicians' view, isn't it, Tina? Back to you.
Thank you very much. We've got a minute left. I shall wrap up ever so quickly. That brings us to the end of the session. I really, again, want to thank both our award winners, our runner-up, and massive thank you to today's speakers. On the screen, you will see, thank you all for joining and supporting Clinical Audit Awareness Week. Tomorrow is the very last day, but there's still time for you to join tomorrow's sessions. There's 2 sessions tomorrow on data-informed improvement from insight to impact. There's a QR code there, or I think you can access it through our website. Speaking of the HQIP website, it is a newly revamped website, and you can get all sorts of information on this topic and other topics on the website. Our search functionality is significantly improved. Don't be afraid. You'll find what you need. It's really great. Next slide. And finally, to say thank you for coming again. We'd love to get feedback. Another QR code. Scan it. Tell us what you thought. The good, the bad, the ugly. It's fine. We love hearing it. And just enjoy the rest of Clinical Audit Awareness Week. Thank you so much for being with us today. And hopefully we'll see you again soon. Goodbye.
Thank you.